Unfortunately, we have a very, very short time because we've got to go right back to the cath lab. But I want to take this opportunity and ask you each in a short way. You know, there's just so many drugs now, and now we didn't even touch on ApoA1 inhibition and all those trials, the outcome trials that are ongoing. It just seems to me it's getting really confusing for the clinicians. Like, what's going to happen at the end of the day? Or do we need something for LPA, one for LDL, one for triglycerides? I mean, it seems to me like there's polypharmacy. So I'll start with you, Mark, because I know that you always see the future. And is there a role for personalizing and using some genetics to better understand how to treat patients best with an algorithm?
Just say for the sake of time that you know, I think for mostly laboratory reasons, we kind of went from total cholesterol to LDL cholesterol. But as Bob and others have indicated, you know, we really need to think about all the atherogenic lipoproteins. And so we would be missing Lp(a), we'd be missing the triglyceride-rich lipoproteins. If instead, in a parallel universe, we had instead focused on ApoB all along, then we'd say, okay, we have a bunch of different drugs to lower ApoB, and we should just pull whatever lever we need. And then, you know, depending on which particular particle, you might want to target one drug versus the other. So I think the guidelines are moving towards recognizing ApoB, and then it'll be sort of the different subsets that add up for an individual, and then thinking based on sort of why their ApoB levels are high, what are the right tools for that person.
No, I agree 100%. Gabrielle, pempedoic acid, we got some you know, I wasn't so impressed with that study, I hate to say, but why do we need pempedoic acid if we have PCSK9 inhibitors? You need to get close and press down on and keep it down.
I think more tools. There are patients who will not tolerate or believe they will not tolerate statins. We can debate for a long time how real is the nocebo effect and the side effects of statins. And I think it's a good solution for those who do not want to self-inject or do not have access to reimbursement of what are still costly drugs. I think the PCSK9 inhibitors are wonderful drugs. As a class, they're extremely effective, extremely safe, extremely well tolerated. Unfortunately, they're expensive, and they're likely to remain expensive for quite a while. And in addition, I think we collectively have failed to fully realize the promise of the class because the trials that we conducted so far were a little short. And I think when we accrue more evidence from the ongoing and future studies, and we're able to demonstrate reduced cardiovascular mortality, the impetus to use that class will increase substantially and hopefully will help bring the cost down.
Yeah, so Pam, just thinking about, we didn't even hear about the fish oils or fibrates or any of those things that we know still lots of our patients are on it. So here you have a patient who has elevated LDL, elevated Lp(a), and also elevated triglycerides. What are you going to do? How are you going to choose? Give us what you're going to do now and what you're hoping to do 5 years from now. You need to press down and keep down. Sorry.
Well, this is where I think you have to look at the patient globally, and you have to go beyond lipids. And you have to kind of look at also what is their A1C, do they have insulin resistance? Because don't forget, we also have GLP-1 receptor agonists and SGLT2 inhibitors. So this is where you have to harness the pleiotropic effects of the drugs. First, you start with lifestyle. And lifestyle, when done appropriately, is going to decrease triglycerides, decrease LDL. And then this is the patient where you want to start with the most cost-effective medications like statins that are generic. And then hasn't had an event yet, so may not get the PCSK9, but this is where you may add a GLP-1 depending on what their glycemic status is. And if there is elevated lipoprotein A, once the trials read out, that's an option. But you got to personalize, and you can't look at lipids in isolation. You have to look at everything else as well.
No, there's no question about that, and I agree with that. So everyone's on Ozempic, right? I mean, that's what's going on. And what about that? Are you going to be out of business, Rob? Because Ozempic seems to fix everything, even lifestyle.
Well, actually, we use a lot of semaglutide because
Whichever one of those things.
yeah, that's Ozempic. You know, it's very effective for weight loss and helps multiple risk factors. It actually helps non-alcoholic fatty liver disease. And in individuals who lose weight, we get an improvement in lipids and lipoproteins. So I think that, you know, taking a major secondary cause of dyslipidemia into account with an agent that's got proven outcomes is something that I actually support.
And then lastly, we've got inclisiran coming as well, or is here actually, but which one of the, does it matter, the PCSK9 inhibitors? Mark, I'll put you on the spot.
Well, I think to reflect the prior comments, great to have multiple different tools. And so we also have Merck's oral PCSK9 inhibitor. And so I think it helps for multiple reasons. You know, one, there'll be some patients who say, I'd rather self-inject than have to go in every 6 months. There'll be people who say, I'd like to take a pill rather than an injection. There'll be people who say, I'd rather have an injection done to me every 6 months, right, twice a year, than have to remember to take a pill each day. And I think then with multiple different drugs, that should hopefully, like in most fields, drive the cost down. And that ultimately, I think, will help our patients. Because if the PCSK9 inhibitors cost a penny a day, there'd be no debate about using them and getting the LDL cholesterol down. But they don't, and so therefore that's the problem for our healthcare system.
Well, this has been a fantastic session in a complex PCI. I mean, come on, you have to give us interventionalists some credit for bringing all of you guys in here to help us drive the events even lower. Thank you so much for being here. Thank you so much.